All right, so the next section is section 4K, and it is your DNR advanced directives, futility of resuscitation initiation, and termination of resuscitation for adult and pediatric. I'm going to probably bore you with this because I'm going to read everything that's on this page because I don't want to miss anything, and this is very important. I could try to simplify it, but I don't want anyone to misinterpret what I'm trying to say or anything like that. So we're just going to read through this real quick. It's not too long. I'm sure we've all dealt with DNRs or advanced directives before, but just a little refresher on it. And to be honest with you, a lot of people are told the wrong things. So there has been a lot of questions on it of recent. So here we go. So for DNRs and advanced directive controls, emergency medical responders, EMTs, and paramedics shall follow a physician's written do not resuscitate order, an Oklahoma DNR consent form, or an advanced healthcare directive accompanied by a written statement from two physicians that the patient is a qualified patient. In many instances of advanced directives, DNR wishes communicated by the patient's family or caregivers, DNR paperwork is missing or incomplete. In such circumstances, contact the Chief Medical Officer or Assistant Chief Medical Officer early in resuscitation within the first 2 to 3 minutes of initiating resuscitation to review the situation. In most of these situations, the Chief Medical Officer or Assistant Chief Medical Officer will be able to determine further resuscitation is not warranted and will be able to cease further resuscitation in concordance with the patient or family wishes. If any of the above confirmed situations cease or withhold BVM ventilation, advanced airway placement, defibrillation, CPR, and antiarrhythmic and or vasopressor medication administration, provide all other appropriate care in accordance with applicable treatment protocols and procedures if the patient is not in respiratory or cardiac arrest, specifically addressing non-cardiopulmonary arrest conditions and maintaining appropriate comfort and care for the patient. So you scroll down to the next page, and we're gonna talk about the futility of resuscitation initiation. So before we jump into that, I do kind of want to talk about this just a little bit. So obviously, we read exactly what's on the page. So just to try to explain it in the most simple way, if you arrive on scene and the family member is telling you they do not want their family member resuscitated, we still have to start if they do not have the proper documentation. With that being said, you can start with BLS only stuff. So just doing CPR and ventilations. Have the paramedic or somebody call online medical control and tell them what's going on if the family's on scene stating they don't want or they have a DNR but they can't find it or whatever the case is. And then let online medical control be the ones to say go ahead and work it or don't go ahead and work it. Just remember, our safety is first. So if it's a case where the family is hostile or violent because they don't want you to work that patient, exit the scene and contact PD, and then contact online medical control as well and explain to them the situation. There have been a couple instances where it has been families saying they have a DNR and can't find it and they never had one, and it was like a medication error, whether they did it on purpose or not. That's not my place to say or to judge, but that's why we contact PD. But we're never going to risk our safety. So if the family is being hostile or violent, go ahead and remove yourself from the situation, contact PD, and then contact online medical control. If it's an instance where the family is not being hostile or violent, you can go ahead and initiate BLS, cardiac arrest protocol, and then contact online medical control and let them make the decision rather to continue to treat the patient or not to continue to treat the patient. But you want to do it quickly. That's why it says within 2 to 3 minutes. You don't want to wait 10 minutes into the cardiac arrest algorithm and then contact online medical control. So we scroll back down here, futility of resuscitation initiation. CPR should not be initiated or continued if initiated by bystanders prior to arrival by emergency medical responders, EMTs, and paramedics if the following clinical conditions representing obvious death, regardless of the cause of cardiac arrest, are present. So this is very important for everybody to know, not just paramedics. No pulse and no spontaneous respirations and pupils fixed, unreactive to light, and one or more of the following: rigor mortis, decapitation, decomposition, dependent lividity. So you will see that again, whether it be on a test or somewhere. So just make sure that you know all of those. We will ask you this when we start running you through mega codes, trauma codes, and anything like that. We'll ask you what are the signs, are the obvious signs of death that you're not going to initiate CPR. And we want you to be able, from memory, to say that the patient doesn't have a pulse, no spontaneous respirations, pupils are fixed and dilated, unreactive to light, whatever it is, and then one or more of the following, whether that be rigor mortis, decapitation, decomposition, dependent lividity. So protocol 4K here: do not resuscitate. Advanced directive orders futility resuscitation and termination of resuscitation, adult and pediatric. So in blunt cardiac arrest, CPR should not be initiated or continued if initiated by bystanders prior to arrival, by emergency medical responders, EMTs, and paramedic if the following conditions exist. So no pulse and no spontaneous respirations and no shockable rhythm and no organized ECG rhythm. So this is pretty key to know right here. In parentheses, it says patient is asystolic or PEA less than 40 beats per minute. So if it is a traumatic arrest, whether that be a car wreck or an assault or whatever it is, and you have any of these, you will not start CPR and the patient will be considered DOA. So if you make a car wreck and the monitor is showing PEA at 46 beats per minute, we will work that patient. If the patient is showing below the 40 beats per minute in PEA, obviously they don't have a pulse if they're in PEA, and they don't have spontaneous rhythm or spontaneous respirations, and then obviously they don't have a shockable rhythm if they're in PEA, then that patient will be considered DOA. In penetrating traumatic cardiac arrest, CPR should not be initiated or continued if initiated by bystanders prior to arrival, by emergency medical responders, EMTs, paramedics, in the following clinical conditions: no pulse, no spontaneous respirations, pupils fixed, no spontaneous movement, no organized ECG activity, PEA 40 beats or less. Unless the above death criteria are clearly met, CPR and other resuscitative efforts should be initiated and aggressively delivered to promote the best chance for the patient's survival. In cases involving relative hypothermia, often involved in water submersion situations, ensure full resuscitative efforts are delivered as outlined in Protocol 11B, cold illness injury, which we'll hit that later on. In cases of lightning strike without signs of obvious death as previously listed in this protocol, ensure full resuscitative efforts are performed. So trauma is pretty much the same, whether it's penetrating or blunt trauma. And we talked about that. Just remember the PEA 40. That's probably something you need to remember. So we scroll down a little bit farther. Termination of resuscitation. We kind of talked about this a little bit ago. This is just going to go into a little bit more detail. Evidence-based medicine supports the practice of field CPR termination in the following: adult non-traumatic cardiac arrest patients who have not responded to full resuscitative efforts delivered consistent with the 2024 Medical Control Board treatment protocols in the following circumstance, in which paramedic or higher level care is available within 20 minutes of first EMS contact with the patient. An adult patient who has a non-EMS witnessed non-traumatic cardiac arrest and is found in a systole or PEA upon paramedic arrival may be considered a candidate for field termination or resuscitation if they do not respond to full resuscitation efforts and, number one, location of cardiac arrest is a private residence or healthcare facility, example, nursing home. So we kind of talked about that earlier. If it's a public place, and we will do this when we do your mega codes and we start training a little bit further on, we will give you a cardiac arrest scenario where you will not get a pulse back or whatever it be, to see if you're going to call for resuscitation orders or for, what am I trying to say? Sorry. If you're trying to call to stop resuscitation efforts from OMD, but you're in a public building street, whatever it is. Just remember, it has to be a private residence or healthcare facility. Nursing homes, skilled living facilities, stuff like that, that is considered private. It's just a public building where the public can be. So that's number one. Number two, ALS resuscitative efforts, CPR, successful placement of advanced airway, successful vascular access, whether that's IV or IO, with medication administration, have been continuously performed for at least 20 minutes without a return of ROSC or conversion of asystole or PEA to ventricular fibrillation, ventricular tachycardia at any time during the 20 minutes of advanced life support. Number three, entitled carbon dioxide is greater than 20 at the time of resuscitation termination. The cardiac arrest did not occur in an absolute or relative hypothermia. I said greater than, it's less than. I apologize. So I'll say that one more time. Entitled carbon dioxide less than 20. The cardiac arrest did not occur in an absolute or relative hypothermia. The cardiac arrest did not occur due to apparent toxic agent exposure. So just kind of talk about that a little bit more because I did say that wrong initially. I apologize. But again, if it's in public, we're taking them to the hospital. If it's a private residence, nursing home, advanced care, anything like that, then we can call after 20 minutes. The only time we're going to call after 20 minutes if it's ALS resuscitative efforts. If they go into a shockable rhythm, we will transport the patient unless OMD says otherwise. So if they are in VFib, just prepare to transport. If they're in a systole and they go into VFib or pulseless VTAC, whatever it is, and they're in a shockable rhythm, we will transport that patient. So don't be confused about that. If they're in VFib for 45 minutes, we will stay on scene for 45 minutes and then transport that patient either when they get ROSC or when they go into a systole or PEA. So just be mindful of that. The 20 minutes is only for a systole or PEA. And then if they are in a systole or PEA for 20 minutes, the CAPNO has got to be less than 20 for us to be able to terminate that care. With that being said, OMD can't override that, just dependent on the situation. That's why we call them and explain to them what's going on. I will talk about this just for a second before I go any further. Whenever you call OMD for termination of resuscitation orders, make sure you have everything ready. Some people will write it down on the back of a code summary paper. Some people have their computer with them. But OMD or whoever you talk to, it will be on a recorded line, and they will want to know the airway, the IO or IV, the medications that were administered. They're going to want to know blood glucose. They're going to want to know capnography, anything and everything that you did. They're going to want to know. So make sure you do it all. You don't want to be in that instance where they ask you, is the patient diabetic, and you don't know, and they ask you if you gave any, or if you checked a blood sugar and you say no, and then you check a blood sugar and the blood sugar is 15. So just cover your basis, and when you call, have all your have everything done, and then have all your information ready so you can call them and give them the full story in a quick manner. All right, so moving on. Adult non-traumatic cardiac arrest patients who have not responded to full resuscitative efforts delivered consistent with the 2024 Medical Control Board treatment protocols in the following circumstance in which paramedic or higher level care is not available within 20 minutes of first EMS contact of the patient. An adult patient who has a non-EMS witness non-traumatic cardiac arrest and is found in a non-AED shockable rhythm upon first care arrival may be considered a candidate for field termination of resuscitation if they do not respond to full resuscitation efforts. And number one, again, if it's a private residence, not public, BLS, ALS, resuscitative efforts, CPR and possible inclusion of successful placement of advanced airway, successful vascular access, IV, IO, and limited medication administration have been continuously performed for at least 20 minutes without return of spontaneous circulation or conversion of non-AED shockable rhythm to AED shockable rhythm at any time during the 20 minutes of resuscitation. The cardiac arrest did not occur in an absolute relative hypothermia or relative hypothermia, sorry, the cardiac arrest did not occur due to apparent toxic agent exposure. So that's pretty much the same. And then here at the bottom, it just says, to be perfectly clear, only after all of the above criteria are met, then an online medical control physician or the patient's personal physician may be consulted for field termination of cardiac arrest resuscitation. Me personally, what I have told all the people that either come to my station that are new medics or people that ask or students that we've taught, just contact online medical control. That's the easiest way. You know it's a recorded line. You know they know what we're doing, why we're doing it, and that's just honestly, it's just the easiest way. So contact online medical control, but again, only after all. They have that bold and highlighted for a reason. So please don't call them 15 minutes in or call them 25 minutes in, but not have given any medication or anything like that. So feel free to come back through and read this if any of that's confusing, or reach out if you have any questions. It can be confusing at times. There's always different scenarios that haven't always been, happened or whatever, anything like that. But if you ever have any questions, you can call. If you're ever in doubt, if you want to stop or you don't know if you need to stop, just call and explain the situation. Everyone on that line is helpful and they want us to do the best that we possibly can. So that is it for Section 4K.